I'm Dr. Patricia Prodigalidad. Many of you know me as Sandy. I am delighted to be here moderating this webinar for all of you. I'm so happy to be welcoming you today. I have the pleasure of being one of the speakers today as well. This is the first time, hopefully not the last, that we have a collaborative activity between the Philippine Society of Digestive Endoscopy and Women in Gastroenterology Asia Pacific, or WIGNAP. We are expecting a big audience today based on the number of registrants from not just the Philippines, but also Vietnam, Thailand, and still other Southeast Asian and Middle East countries. Before anything else, let me introduce myself a little bit more. I currently sit in the board of the PSDE as treasurer. I am an interventional endoscopist and clinical associate professor of medicine at the University of the Philippines, Philippine General Hospital. I did my gastroenterology fellowship at the same institution and later completed my advanced interventional endoscopy fellowship at the California Pacific Medical Center in San Francisco. I am currently the head of the section of the Advanced Interventional Endoscopy of the Institute of Digestive and Liver Diseases at the St. Luke's Medical Center in Taguig in the Philippines. We have a total of 3 lectures today, focusing on the basics of endosonography. The first lecture will be given by myself, followed by lectures from 2 well-respected women gastroenterologists who are also expert interventional endoscopists. We know that some of you are already very familiar with endoscopic ultrasound, but still many of you are only now really developing an interest in the field. At the end of this webinar, we hope to be able to extend enough information and hopefully develop your interest some more and help you develop an understanding about how endosonography or endoscopic ultrasound is essential in any GI endoscopy unit. Before we begin, I'd like to review some house rules. Actually, it might not be a problem because everybody will be on mute already. There will be a query box at the right side of your screen where you can type in all of your questions. And we will try to answer all relevant questions at the end of all 3 talks. So as I have a dual role today as moderator and speaker, I will take this opportunity to first introduce the president of the Philippine Society of Digestive Endoscopy for a short opening message. Let's all welcome our good friend, Dr. Benjamin Gerardo A. Perez. Benji, please, you have the floor.
Thank you, Sandy. Good evening, dear colleagues from the Philippines, Vietnam, Malaysia, Thailand, and other countries tuning in. I'd like to welcome you to this international webinar on basic endoscopic ultrasound, another online learning session arranged locally by the Philippine Society of Digestive Endoscopy through the efforts of PSDE Vice President Dr. Julius Soriano, who has been meeting with medical industry companies for partnerships with PSDE in holding webinars. In spite of the limitations imposed by the present pandemic on our conferences, the PSDE is committed to serving its members and their patients, including in continuing medical education. These webinars allow us to widen the pool of experts willing to share their experience and knowledge. I'd like to thank WIGNAP, Women in Gastroenterology Network Asia Pacific, for being our partner in this webinar, which is of great significance since, as far as I know, the majority of local GIs now are female. Thank you to our speakers, Dr. Sharmila Sachithanandan, WIGNAP Chairperson, Dr. Nonthalee Pausawasdi of Mahidol University in Thailand, and our very own Dr. Patricia Prodigalidad, PSDE Treasurer, for sharing their knowledge with us today. I'd also like to thank Pentax Medical and NPK Medical Trading Incorporated for sponsoring this activity. I hope you will all learn a lot from these lectures and look forward to our future webinars. Thank you for your attendance and good evening.
All right, thank you, Benji. Next, we also have a message to be given by the founding president of WIGNAP. Since she will be also speaking, this is probably the best time for me to introduce her. Aside from being chairperson of WIGNAP, she practices as consultant gastroenterologist at the Ramsay Sime Darby Medical Center in Kuala Lumpur, Malaysia. She completed her training in gastroenterology at the Mater Misericordiae Hospital in Dublin in Ireland, and has since held several positions in many other institutions as clinical specialist and consultant physician in gastroenterology and hepatology. Aside from these, she has sat as board member in several other GI societies in and outside of Malaysia, and currently serves as treasurer of the Asia Pacific Neuroendocrine Society Advisory Board. Everyone, please help me welcome Dr. Sharmila Sachithanandan. Sharmila?
Hi, good evening, everyone. Can you hear me? Thank you very much for the kind introduction, Sandy. And it really is a great honor and privilege for WICNAP to collaborate with the Philippine Society of Digestive Endoscopy. Lovely to meet you, Dr. Benjamin. And, we've been looking forward to this, as you said. Sandy and I have been planning this for a couple of years, and it's great that it's come to fruition today. I'd like to thank Pentex and the local sponsor, NPK, for organizing this as well. And we will start off with telling you a little bit about WICNAP. As you know, WICNAP stands for Women in GI Network Asia Pacific. And this is something close to my heart and Nonthalee's heart. Basically, this was founded in 2014, and it was a Pentex-driven initiative. So we're very grateful to Pentex for getting us to start this whole initiative. And Boston Scientific is also another great sponsor that we're grateful for over the years. Basically, we started as a group of female gastroenterologists from 9 Asia Pacific countries, and initially supported by Pentex Boston and Cook. And today, in 2020, I'm happy to say that we have representatives from 15 countries, and we have many more sponsors on board as well. The aims of WICNAP are basically to support women in GI medicine, to develop leadership, to foster mentorship programs across the Asia Pacific and worldwide, and of course to strive for gender equality. And what else could WICNAP contribute? Basically, over the last 6 years, it's been an inspiring journey for us, meeting many women from different parts of the world, hearing all their challenges, and actually realizing that we all have similar challenges, and by sharing our experiences, we can actually try and overcome this. And how we've done this is we have training workshops, hands-on workshops on EUS mainly, and we're looking into other workshops like basic GI endoscopy and ERCPs at some point. Our other big point is trying to have a session at every APDW, which we have managed to do so in the last 6 years. So basically at every APDW, you will see some flyer to say that there is a WICNAP session. And what we've had is we've had video contests, and we've had hands-on workshops and get-togethers for women to network and meet one another, and then specific training programs as well. Now, 2 years ago, we formally got registered as a society called the Gastrointestinal Task Force Asia Pacific Society. And you can see on the board of the group that we have both men and women, because we do believe that it's a combined movement that is going to be able to effect any change. And we have our 3 great VIPs, like we like to call them, Dr. Ryan Ponadure, who is the president of GI TAP Society, Dr. Chris Kaur from Singapore, and Dr. Tawi from Thailand, who have really been instrumental in helping WICNAP take off ground as well. So this is a WICNAP timeline to just show you over the last 6 years what we've been up to. As each year progressed, we got more and more busy. We've had meetings, of course, at every APDW. We have been involved in the Australian Gastroendoscopy Society. We've been involved with World Endoscopy, the inaugural session in 2017 in Hyderabad. We've had sessions in Japan, in India, Hong Kong, Thailand, and more recently in America. And in 2020, we had great plans to do quite a few things, but unfortunately, due to the pandemic, some of that is stalled. Like APDW is supposed to be in Malaysia this year, but that's been moved to next year. But what we did manage to do is a few webinars. So at the start of the year, we did a session with the Mayo Clinic. We had two speakers, Liz Rajan and Fergus Gleeson, who came to Malaysia. So we had a nice meeting there. And then Prague Endoscopy Days is something historical. This is the first endoscopy meeting where all the faculty were female. And then we had one in Myanmar, and subsequently our Rio meeting, which I'll tell you a bit more in a second. So the Prague Endoscopy Days, our co-founder, Payal Saxena, was one of the faculty, and it was really an incredible meeting. I think first time in history. It was an all-female faculty, so very inspiring. And then we worked with Amrita Sethi's group, Women in Interventional Endoscopy, and Simone from Brazil, SOBAD. And together we had planned this wonderful meeting called World Wonder Women in Gastroenterology, which was held in Rio in March. And unfortunately, many of us could not make it, but those who were there actually carried the show through, and it was a fantastic meeting. And then we've also had a webinar, our first webinar with the Pakistan Society of Gastro and Hepatology. So that went very well. I think there were about 24,000 views, which was incredible. And nice to meet ladies on that side. And then Majida Bukhari from Saudi organized this webinar as well. And Nonthalee has been very busy with marathon webinars as well. So this was one she did just a couple of weeks ago. And of course, today we have this one. So this is a picture with Sadie when you were faculty at the meeting that we had in, I think it was Korea. Yeah, Seoul, 2 years ago. So I'd like to share that, this is a group effort, and it really what we have achieved today is not possible without my two co-founders, Nonthalee, who you'll meet shortly, and Payal Saxena from Australia. And these are all the other countries that are part of WIGNAP. More recently, Pakistan has joined us as well. And when you set up women's groups like this, we know that one size does not fit all. We know that not everyone is happy to have a group like this, but then there are many women who actually have challenges and have issues and are unable to voice them. And so we are very happy to be that platform to be able to raise issues and to help, women in GI to overcome all these. And as I said before, one of the biggest things that we try to do is to have an annual meeting at our APDW, which is our local version of DDW or UEGW. Our biggest and most frustrating challenge is to get a regular slot in prime time. Other organizations like around the world in America and in Europe, they all acknowledge and support these initiatives. We're hoping that we will get that slot regularly soon. Somehow we've managed to get a session parallel at every year, but we hope to be in the main program at some point. A few good men. I think you need more than a few good men to support and basically create that wedge. And, we're grateful to all these men here. They've all helped to introduce WIGNAP and to introduce the women in GI in their countries. And together we have worked together. There is a space for many more people to come on board as well. What else could WICNAP provide? I think role models. So female established organizations provide positive, visible role models. Women get inspired. Men see that women can do it. And it's a nice time to be honest. We can all share our own experiences and learn from each other. And male mentors are equally as important as female mentors. So in Asia, are we different? We know we are a heterogeneous group, a big continent, wide variation in social cultural views. There are many issues, women and colonialism, sexism challenges. And we know that East Asia versus Southeast Asia, there are slight differences. So when we first started WICNAP, we thought, we weren't sure what exactly we were dealing with. And we thought we would, carry out a survey and see what the situation was. Before going on to the survey, when we look at the Global Gender Gap report, this is a report that looks at 4 key areas: health, education, economy, and politics. And you can see that most of the Asia Pacific countries are in the bottom half. There are about 110 countries. Most of the countries are in the bottom half of this rank. Thailand is pretty good at 71. But I'd like to share that I think Philippines is incredible. You are at the highest of all Southeast Asian countries. Philippines is actually at the top. And so that says a lot. I think, as Dr. Benjamin was saying, that a lot of your GI consultants are actually female. We'd like to learn a lot more from all of you as well. So basically, we sent out this survey to all our Asia Pacific WICNAP representatives, and these 7 countries participated. And some of the questions that we asked were whether the people who took the survey, were they trainees or consultants. Many of them were already consultants, what age group they were in, whether they had a higher research degree, whether any of them were directors or head of departments. You can see that majority, almost 80%, were not. Have they ever directed an endoscopy course? Many of them had not. And even leadership positions, majority were not in that. So is there a need for something like WICNAP? We know that majority of medical school graduates in Asia are female, apart from East Asia. In fact, in Malaysia, I think almost 60 to 70% of graduates are female. Most women doctors do have equal access to medical school, and they are not prevented into getting into gastroenterology. However, many report lack of career advancement, very few roles as faculty, as speakers at national and international meetings, and very, very few as endoscopy faculty, and even fewer as course directors. And also they are, underrepresented in leadership positions in academia as well. So you wonder whether the glass ceiling is shatterproof. Now, we also got comments, and we've kept this anonymous so that no one knows who said what, but basically these were some comments from female gastroenterologists around. Some said that, they felt less privileged and supported. Someone said, they felt the social pressure to have to drink alcohol, and, the usual of no option of part-time work when your child is young. Work-life balance is tough. Those who, choose to stay at home resent that they cannot fulfill their full potential in terms of career. Many actually said that they do feel respected, but, where it comes to interventional therapeutic procedures, they feel they're not given the same amount of respect as their male colleagues. And then, of course, that whole issue about when they hit the maternal wall, you can't get pregnant during training and balancing career and family. And then there was this very interesting one where someone said they were very happy there was a women's group, but they were afraid to be seen as part of it because they thought they might upset their male colleagues. So all interesting information from that survey. Basically, it summarizes that, there are cultural differences and gender differences affecting work and career for young female trainees. There is a desire for change. There's a desire for more mentorship programs, career developmental skills and personal developmental skills as well. When we look at East Asia, we know that less than 21% of doctors in Japan are women, and it's tough. They have to choose between family and career, and many women are actually choosing work over having children, and fertility rates are very low, very difficult to get training positions there as well. But Japanese women are incredible, and when we had a session with them in Kobe, they shared with us, their challenges, and they shared with us ways that they've gone about trying to overcome it. And one of the things that they have done is that they have workshops for women, by women. And one of the things they've done is, like for ESD, they have 2-3 day sessions where it's just women teaching other women, and they found this a great way to make friends, and they had good relationship amongst themselves and wonderful support apart from just learning endoscopic procedures. And this is a slide that one of our Japanese colleagues shared with us, and you can see that it's something quite commonly seen elsewhere in other countries as well, where at the start of residency, you can see that there are quite a few females, but as you move up the ranks, at the top of the pyramid, you can see that very few, 1 in 10 is a female. And this is a very interesting graph that they showed us, the activity ratio of women doctors. Basically, between the ages of 25 and 35 is the biggest drop in women in the workforce in medicine. And that's the time when, they decide to get married or they have kids, and they have to choose between, work and family, and they have to leave their careers to manage the situation at home. And then you see that very few actually make it back into the workforce because there's not enough support to help these women to get back into the workforce. However, as I said, the Japanese are incredible. So in the last 5 years, they have taken it into their hands to try and improve the situation. And Naomi, who shared this with us, that there is a women's committee set up with the Japanese Gastro-Endoscopy Society. There is a registration bank set up for all women doctors. They have their own webpage where they have information on crashes in childcare and care for the aged. And in 2018, their own Ministry of Health, Labour and Welfare launched a project to try and help women pursue their career in medicine. And I think the situation is similar in Korea, but again, a diversity committee has been set up in the Korean Society of Gastro and Endoscopy, and they're looking into this as well. What about Southeast Asia? I think this covers places like Malaysia, Thailand, Myanmar, Singapore, Australia, where majority of medical school graduates are female. There is gender equality in medicine, and selection into GI is not an issue. Within gastroenterology, there are many women in oncology, in IBD, fewer in endoscopy, and fewer as faculty. Climbing the ranks and up leadership is maybe not automatic or meritocratic. Most women in academic centers are not married. Work-life balance is a major challenge. So many women drop out of medicine because of the traditional roles. We know that hired help is available in Southeast Asia, but unlike the West, they're not properly trained. So although you have someone minding your child, you may not go to work with great peace of mind. Childcare standards are generally better in the West. We are the sandwich generation. We are, very fortunate to have our parents and grandparents to look after our children, but they are also aging, and women often have to be the ones to look after the children and the elderly and the sick, as we have seen in the COVID pandemic as well. And paternity leave is a norm in the West. Hopefully, this will be something that we in Asia can institute. But I think, it's a generational thing as well. I think, everything is changing. Young men and boys today are being brought up in a more general, neutral society, and they're very conscious, and this is not really a major issue, hopefully, in the future. So to summarize the top challenges that women feel, women lack confidence and feel less trusted than their male colleagues, and this so-called imposter syndrome, where they feel that their success is not due to their own intelligence or capabilities. They think that they got there because they were lucky, or they happened to be there at the right time, right place, and not due to their own abilities. So we need to encourage more women. We need to show them that gastroenterology is a fantastic subspecialty, create opportunities and platforms to showcase their skills, and to find ways to help women who have taken a break to re-enter the workforce after the break. Women as leaders have to gain the respect of their male colleagues. So again, women have to be professional, they have to be technically competent, positive discriminative policies or quotas. To some extent, these may be necessary initially, but we don't like to have quotas. I think most women want to be in that spot because they're good enough and they earned it. So it should be meritocratic. But then again, change starts from within the community. So women need their male colleagues to sponsor them and to support their nomination into leadership positions if they are up to the mark. Women are nurturers. They have to balance work and family. Men normally don't have to choose. There are sacrifices to be made, especially when you hit the maternal wall. We have to be courageous to make these difficult decisions and be brave about them. But I think men also need to be supported. Yeah, I think some men are happy to be house husbands, and they need to be supported to be able to make those decisions. And then this question, which is quite interesting: what if you become more successful than your husband? The cultural expectation in Asia is for women to take a back seat, to mind the household and deal with family responsibilities. I think when you get married, you have to have an honest chat with your spouse. They need to understand what your aspirations and your career plans are. And it's a difficult issue, but men also need that support, and you have to make that change and decision together. Finally, just to say a few words that, this COVID-19 pandemic has been an opportunity to spotlight the often unrecognized role of women. I think this pandemic has shown us that women possess innate, unique qualities that can make them very effective leaders. These women leaders broke many stereotypes. Many of them were young, they're very confident. They have come from same-sex parents. All these stereotypes that they have basically shattered. Majority of the healthcare workers were female, mothers and wives who did not shirk away when they were called to serve. And meanwhile, while women were out there, men were at home. They stepped up as fathers and husbands. And we also found out that, working from home is possible. And the global gender gap showed us that many of these women are from countries where they have been elected into power by progressive societies. And this is just to say that even within medicine and gastroenterology, change has to happen from within our community. And we need more women in leadership. We know that these women have played a central role in the pandemic. We know that 90% of some countries, the world frontliners are all female. 70% of the world healthcare staff are female, but only 25% of global leaders are female. Less than 1 in 5 are women at the table making important decisions. And, it is just highlighting the fact that we need to increase the representation of women in positions of influence. So how can we help each other? We need to support each other. Both men and women have to strive to achieve this equality and effect change, economic, institutional, and social change based on political will is necessary to overcome this imbalance. And at the end of the day, I do believe that it's regardless of race, religion, or gender, every human being deserves to reach his or her potential. And with that, I'd like to share with you a very quick video. Manjeet, over to you to show our video. Thank you.
I'm sure everybody now, we're all very familiar with WIGNAP, and I'm sure after this lecture, we'll be getting a lot of questions about whether or not some lady gastroenterologists in the Philippines or even the other countries, the women in other countries listening today, they might want to join WIGNAP. So please prepare for that. All right. Okay. Of all the three speakers, I probably have the easiest job today. I shall be giving a short talk on the basics and fundamentals of endoscopic ultrasound. My purpose is more than anything to give you enough understanding about ultrasound or endoscopic ultrasound, and maybe give you a good enough foundation so that you could hopefully find it easy to follow the subsequent topics or talks as they are being given. So let me just share screen. All right. Do you see it? All right. So
Green Hills.
we shall be defining, today we shall be defining ultrasound. We shall be discussing basic ultrasound physics. We'll be exploring endoscopic ultrasound scopes and probes. We shall be looking at common ultrasound terminology, and we'll be breaking down concepts so they are easy to understand. And we'll briefly review the indications, the contraindications, and complications that are related to EUS. All right, so what is endoscopic ultrasound? Simply put, endoscopic ultrasound combines endoscopic visualization, or is a combination of endoscopic visualization and high-frequency ultrasound. It allows for precise differentiation of the individual layers of the GI tract, and it helps direct imaging of surrounding organs and tissues. The general EUS indications would be staging of tumors of the GI tract, the pancreas, bile ducts, and mediastinum. We use EUS for evaluating abnormalities of the GI tract or adjacent structures. We do tissue sampling of lesions. We're able to do tissue sampling of lesions with EUS. Of those lesions within or adjacent to the wall of the GI tract, if they're close enough, we are able to evaluate abnormalities specific to the pancreas, like masses and pseudocysts, and even evaluate chronic pancreatitis. We also are able to look at the biliary tree very closely and very well, and we're able to provide endoscopic therapy under ultrasonographic guidance. So how does it work? Please be patient with me, just with my introducing a few concepts of ultrasound, but trust me, it's very easy to understand, and it will help guide you through whatever it is you will be encountering, the terms that our speakers are going to be throwing at you a little bit later on. So how does ultrasound work? So if you imagine this line representing all the possible audio frequencies. If you had this line, then a portion of this would be audible, right? So an audible means it can be heard by the human ear. And it is said that the frequency would be 20 hertz to about 20,000 or 20 kilohertz. So anything below this threshold is called infrasound. And so simply put, anything over audible threshold would be ultrasound. In diagnostic medical ultrasound, the frequency is typically between 1 to 20 or 20 plus megahertz. But EUS utilizes the high ultrasound frequencies, like 5 to 20 megahertz, 7.5 megahertz being the most frequently used ultrasound frequently. And this generates a high resolution image in the near field, of course, with limited penetration depth, ranging maybe from 1 to 2 to 5 to 6 centimeters, depending on the ultrasound frequency that is used. So let's use something very familiar to all of us, and this is an audio speaker. This audio speaker, it uses electrical energy, and the electrical input causes the speaker to pump in and out. I'm sure you've observed this with the speakers that you had at home, especially when you were younger. So this pumping in and out generates sound waves that travel through the air, which are then heard by the human ear. In the case of ultrasound, and for our purposes, endoscopic ultrasound, the transducer of endoscopic ultrasound receives electrical input, and this produces high-frequency sound waves that travel freely through fluid and soft tissue. However, When the sound waves encounter a more solid or dense structure, these sound waves are then reflected back as echoes. So for example, the sound waves that will travel freely through bile or liquid in the gallbladder, when it hits a gallstone within the gallbladder, there is then an echo back to the machine. Before we move forward, I want to talk briefly about the transducer at the tip of the endoscope. Located within the transducer are what we call piezoelectric crystals. These piezoelectric crystals receive electrical pulses, and when these electrical pulses are applied to them, the electrical pulses cause them to expand and contract. And this expanding and contracting of the crystal then results in transmission of ultrasound pulses. So the sound wave, after it hits tissue, will be reflected back to the transducer, and the piezoelectric crystals then convert the ultrasound waves back to electrical signals that are then fed into the machine to produce an image. Note that in producing an image, the pumping in and out of, or the expanding and contracting of the crystals to produce ultrasound waves occur maybe 1% of the time, because the rest of the time is spent waiting for the reflected sound waves or the echoes. More on basic ultrasound physics and terminologies, but before all of that, we talk about a few concepts like depth and brightness. So depth is a function of distance to the transducer. The longer the time it took for the sound waves to return to the transducer means it had to penetrate deeper into the tissues. Conversely, the more shallow that ultrasound wave must penetrate, the shorter the time it takes for the sound wave to return to the transducer or the ultrasound machine. And brightness, you can think of it as the volume or the intensity of the returning echo. The louder the returning echo, the brighter it will appear. And a less intense returning echo will appear darker. Again, as we touched on before, as the speaker pumps in and out, it generates sound waves. As the speaker pumps out, it compresses air molecules, and these are areas of highly compressed air molecules. They are called compressions. As it goes back in, it creates a vacuum effect, and these areas of low pressure, they are called rarefactions. So to discuss the characteristics of a sound wave, it's easier to depict the compressions as peaks on a sine wave and the rarefactions as troughs on a sine wave, although we understand that a sound wave is not a sine wave. Now, what is wavelength? Wavelength is the distance between a peak and a trough and a trough. And similarly, the time between a peak and a trough is called a period. So wavelength is a function of distance and period is a function of time. The next characteristic we want to talk about is amplitude. So amplitude is the height of the peak of a sine wave, or how high pressure the compression is. This is the loudness or the intensity of the sound. So the higher the amplitude, the louder or the more intense the sound. The lower the amplitude, the less the intensity of the sound is. Then lastly, we look at frequency. So you're going to hear frequency a lot. Frequency is how many sound waves travel past a certain point in a certain period of time, and this is measured in hertz. And hertz, these are cycles per second. So the more waves that pass a given point in a second, the higher the frequency. The less the sound waves that pass a given point in a second, the lower the frequency. If we compare the top wave to the middle wave, this top wave to the middle wave, I'm not sure if you're seeing my cursor, you'll notice that the wavelength of the top wave is longer compared to the wavelength of the middle wave. Therefore, since the wavelength is longer, the frequency is going to be lower. And therefore, the pitch of the sound wave on top is going to be lower than the middle wave. If you look at the amplitude of the top wave compared to the middle wave, the amplitude is lower. Therefore, the volume or amplitude of the top wave will be quieter than the volume or amplitude of the middle sound wave. And the bottom wave has an even longer wavelength, therefore a lower frequency and also a lower amplitude. So therefore it will be lower and quieter. The key concept is that frequency is inversely proportional to wavelength. The bigger the wavelength, the lower the frequency, and the smaller the wavelength, the higher their frequency. Okay, so what does this mean? And what does it have to do with diagnostic medical ultrasound or endoscopic ultrasound? It all boils down to the concepts of resolution and penetration. Resolution is simply how pretty, how defined, how detailed the image is. And penetration is how deep the ultrasound wave is able to penetrate into the patient's tissues to generate an image. And again, all of these are all a function of frequency. So as you increase frequency, you increase resolution. As you decrease frequency, you decrease resolution. And conversely, when you increase frequency, you decrease penetration. And when you decrease frequency, you increase penetration. So I hope that was clear. But just remember, ultrasound also undergoes a lot of tissue interaction because it also goes through refraction, scattering, and absorption to produce a representative image of a tissue. So some other terms that I'd like for you to be familiar with. Echogenicity. Echogenicity is a measure of acoustic reflectance. It is the ability of a tissue to reflect an ultrasound wave, or the ability of to bounce an echo. The source of echogenicity is impedance mismatching. So impedance can be thought of as a resistance to flow of mass or energy from a pulsatile source, unlike resistance, which generally assumes a steady source of mass or energy. When two tissues have different acoustic impedance, only some of the ultrasound or ultrasonic energy will be reflected backwards. So echogenicity is higher when the surface bouncing the sound or the surface that produces the echo reflects increased sound waves. So you will encounter in relation to echogenicity a few other terms like hyperechoic, like when they say there is a hyperechoic lesion or an isoechoic lesion or an anechoic round structure. Anechoic is a black structure, or hypoechoic. Okay, so isoechoic means a lesion exhibits the same brightness and darkness as surrounding structures. Anechoic structures are black. They are fluid-filled structures like blood vessels, cysts, or ducts. And yes, it might be difficult to differentiate different anechoic structures from each other, so we generally have to use other modalities, such as Doppler flow. Hypoechoic are generally gray structures, and they are typical of solid mass lesions, while echogenic or hyperechoic lesions are white. And these are characteristics of stones, calcified lesions, and even fat. So just a few pictures to show you or give you, hopefully you're able to appreciate what I was talking about. When we say a lesion is hyperechoic, it is whiter than the surrounding structures. When we say that a lesion is hypoechoic, it is darker than the surrounding structures. When a lesion is isoechoic, it is similar, or the color, or the brightness, or the darkness of the lesion is similar to surrounding structures. And when it's anechoic, again, I said it would be black. So just a very good diagram to show you. Hopefully you are able to appreciate much more that anything that is black is fluid. These are anechoic structures, like this cyst over here, and blood vessels. Then you would have hypoechoic lesions like tumors and lymph nodes. Then you would have hyperechoic lesions like fat and stones, right? So fatty tissue and stones. So remember, echogenicity could also be a function of water content. The more water, the less echoic. The less water, the more echoic. So let's talk about endoscopes or echoendoscopes. The echoendoscopes are similar to standard endoscopes, but they have oblique viewing optics and an ultrasound transducer at its tip. So together with an inflatable water balloon, it also has an inflatable water balloon to enhance acoustic coupling. There are also dual-purpose buttons on the endoscope that handle or allow for air insufflation and suctioning of the gastrointestinal lumen, as well as inflation and deflation of the balloon. So echoendoscopes also are Doppler capable, and it allows, like I mentioned earlier, it allows for identification of blood vessels. Okay, just a brief description of a radial echoendoscope. So we have two types of echoendoscopes, a radial and linear echoendoscope. And then we have catheter-based probes as well. So the radial echoendoscope scans in a plane perpendicular to the axis of the endoscope. And it produces an eggshell image similar to that of CT scan. And it's very useful in staging and evaluating subepithelial lesions, like in the esophagus, the stomach, the proximal duodenum, and the rectum. The linear echoendoscope scans in a plane parallel to the axis of the endoscope shaft. And this plane of imaging allows for visualization of needles as they are advanced beyond the tip of the scope, and thereby facilitating sampling of tissue or cystic fluid, like when we do an FNA or an FNB. And the visualization of devices are also possible as they are advanced through the echoendoscope channel. So because of this, we are able to visualize stents and coils, maybe fiducials and neurolytic agents. So we also have high-frequency mini probes. High-frequency mini probes allow for scanning frequencies in the range of 12 to 30 megahertz. These are catheter-based probes, as I mentioned, and they can be advanced through accessory channels or working channels of forward-viewing endoscopes. And they are useful for evaluating superficial lesions, subepithelial lesions, especially in difficult-to-reach places like the proximal colon or the small bowel. So just a few things that we remember as endosonologists so that we can obtain optimal imaging. We need to remember that optimal imaging requires modulation of several factors. So sound waves travel best through water, whereas air creates noise and reverberations, resulting in EUS image degradation. Optimal endosonographic images are therefore attained either by filling the GI lumen with water or by suctioning air out of the lumen and filling the echoendoscope balloon with water to improve acoustic coupling. When imaging a wall lesion, the ultrasound beam should ideally be perpendicular to the lesion to avoid imaging artifacts. And the area of interest should be within the focal zone of the ultrasound probe, usually about 1.5 centimeters from the probe. So again, remember the factors that influence the quality of the ultrasound: contact and distance between the ultrasound transducer and the tissue of interest, installation of water. This can improve image quality by improving acoustic interface with the tissue, also inflating the transducer balloon. And then the presence of air and water. Remember that they can cause reflections, reverberations, or artifacts, so that suctioning and removing bubbles can help as well. So this is just one picture. You are going to be seeing a lot of this when Dr. Sharmila starts her talk again, but I just wanted to show you how easy it is for us to see and to evaluate the different wall layers of the intestine. This one is one view that you are able to get using a linear echoendoscope, where you see the pancreas behind the port of confluence. And you see how the pancreas is very close to the transducer, so we're able to do a lot of biopsies, a lot of injecting in this area. Some practical EUS aspects and logistics. So sedation, we like to talk about sedation. I personally feel that it's important to have a patient sedated when it's an endoscopic ultrasound that you're doing. One, because the scope is a little bit thicker, so it can be difficult for the patient, and the procedure can potentially last longer, especially if you plan on doing some therapeutic maneuvers. Preparation is pretty much the same. For upper EUS, you do a prep for an EGD, which is practically just keeping the patient on nothing per RM. And then for lower EUS, it's similar to the prep of colonoscopy or flexible sigmoidoscopy. And also, one needs to remember the reach of our scope. So when we use an upper or perform an upper EUS, whether via radial or linear scopes, the distance that we go can be as far as the second portion of the duodenum, maybe a little bit deeper down if we're lucky. Lower EUS, typically up to 15 to 18 centimeters proximal to the anal verge. And for areas that are not easily reached by these two instruments, then we use the through the scope mini probes that I mentioned earlier. Okay, I'm down to my last three slides. We'll talk about contraindications, and maybe not three. We'll see. So for contraindications, of course, we need to consider sedation problems or possible sedation issues in cardiorespiratory risk. So if they are unacceptable, then we abort. If we are to do any therapeutic procedures, of course, if the INR is greater than 1.5, especially if we're planning an FNA, we abort. And if the platelet count is less than 50, if there is the presence of intervening structures, or if there is altered anatomy prohibiting access to the echoendoscope. As far as complications are concerned, we'll just touch on a few. Infection is not very common as a complication of EUS, but if a patient were to develop an infectious problem after an EUS, it would typically be after aspiration of fluid, usually a pancreatic cyst. And the infection rate remarkably goes down with prophylactic antibiotics prior to and after the procedure. However, there are multiple factors that you need to consider with regards, avoiding or trying to avoid infections. And one is that you shouldn't be doing multiple needle passes. So if we have a cyst, we only want to do one pass if we can. And then we need to completely aspirate all the cyst contents. Perforation is also very rare in experienced hands with regards EUS. It's only a little bit higher than EGD or colonoscopy. Typically, if you were to get a perforation doing an EUS, it would be if you were performing it after you had performed another therapeutic procedure like dilatation of an esophageal cancer. After EUS, an FNA, it's possible to get pancreatitis, but lower when you're dealing with solid pancreatic lesions, a little bit higher with pancreatic cystic lesions. But all of these, they may be associated with the number, again, the number of needle passes. It may be, and they may be minimized, or the issue of pancreatitis may be minimized by limiting the amount of intervening normal pancreatic tissue. That means we hope not to be hitting too much normal tissue as we are trying to get to a lesion. So I think this is my last slide. Thank you very much. I hope you guys learned a few things from that. And really, it was so that I could maybe help you go through or understand the lecture or what our subsequent speakers are going to be talking about. So thank you very much. I'm going to stop sharing now. All right, am I still on? Okay, so that was my lecture. We are going to proceed to the next lecture to be given by Dr. Sharmila Sachithanandan. Sharmila, please go ahead. Oh, sorry. Me or Sharmila?
Dr.
Okay.
Sharmila, please unmute.
Okay,
Thank
we're
you.
okay now. Thanks, Sandy, for doing the hard bits. It was an excellent lecture on the physics of ultrasound. For the audience, don't be intimidated by the physics. I promise you, I was really bad at physics, but I totally love EUS. So, there's hope for all of us. And I've kept this lecture basic because I think it's very important to go back to the basics to understand the fundamentals before we can go on to things like FNA. And if you look on everywhere now, it's all about EUS-guided biliary drainage, gallbladder drainage. It's all very exciting. But to get to that point, we need to understand where it started from. Okay. So Sandy's covered a lot of the basics, but I will just go through a few things. As you know, that EUS is a combination of endoscopy and ultrasound that provides transmural visualization of the gut wall and the adjacent organs, especially the pancreas. And it provides high-resolution imaging, so we can identify very small lesions that are often missed by other modalities, such as CT and even MRI. And with EUS, we can determine therapy based on, the echogenicity, as Sandy had mentioned just now, the vascularity, the margins of the lesion, the size, whether the lesion is intramural or extramural. We can tell which layer the lesion is in and whether there are adjacent lymph nodes, and if EUS FNA is necessary to obtain tissue. Okay. So the EUS procedure, it's one of the most important advances in GI endoscopy. It is minimally invasive. It has become standard practice in most centers of excellence, and it's very similar to an upper GI endoscopy. It is performed with conscious sedation in most places, and the whole procedure takes about 20 to 30 minutes. Usually it's an outpatient procedure. But as easy as it looks, I have to say that EUS has a steep learning curve, and it is highly operator dependent. And I'll talk about this in the next couple of slides. But basically, as Sandy's already mentioned, you need an ultrasound scanner and the Echoendoscopes. And this is the latest Pentax scopes, the J10. You can see they're very nice, slim, neat looking, and the images are really beautiful. Two types of Echoendoscopes. We've already heard the radial that gives you a 360 transverse cross-sectional view, and the linear scope, which is a sector scanning, and you have a port to do your FNAs. Now, if you had to choose between the radial or the linear, if these scopes are not cheap, they're quite expensive to have the whole setup. And if you are a trainee, you have limited time and you want to pick which one to learn, I would say go for the linear scope straight away. That's my personal choice and advice. We can discuss this later. The reason for that is that most cases which require EUS, you can do it with the linear scope. In fact, 90% of cases, you can do it with a linear scope. 10% of cases is where you might need the radial scope, which is what I'm going to cover in this lecture. Okay. And one of the basics is that you have to spend time to know what's normal before you go on to what's abnormal. So over here, it's not about putting the scope down or, it's not hard. If you know how to do an OGD, you would know how to put the scope down. But it's what you're looking at. It's ultrasound images. When I first started EUS, when I approached someone, can I learn EUS? They said, have you done any abdominal ultrasound? I said, no. They said, go look at 100 abdominal ultrasound before you come back to me. And that was quite disheartening, but I can understand why that was so, because you want to look at the images of how the liver looks like, what the pancreas looks like, what the kidney looks like. You want to know what those things look like when you put the scope down. Yeah. So I think it's very important to spend time watching and learning before even touching the scope. So in a lot of centers where they offer EUS training, I think in a high volume center where there are at least 200 cases a year, you would spend at least a month and a half just watching before you're actually allowed to touch the scope. And I think there's a good reason for that. The other thing that we need to know is it's a jigsaw. It's not just putting the scope down and having a look at the lesion and saying, oh yeah, I can see this, I can biopsy this. It's like a jigsaw, yeah? So we need to know the clinical presentation. In your mind, you need to have a differential diagnosis. You have to look at the CT or the MRI, and then you do the EUS, because very often it's putting it all together and then, coming up with a differential. Like, for example, I'm sure Nonthalee will go through like a mass in the head of the pancreas doesn't always mean it's pancreatic cancer. Yeah, could be autoimmune, could be TB, lymphoma. So you got to know the case before you put the scope down. So radial EUS is a purely diagnostic scope. As I said just now, it's used in mainly 5 to 10% of cases. You can't do biopsies with this. The basic principles of having a balloon, you need to know how to fit the balloon. You need to have no air in the balloon. And as Sandy mentioned just now, within the lumen of the stomach, the principles of sucking air and having no air between the interface of the balloon and the stomach walls, yeah? And then simple things like making sure the cords are not coiled, the valves are okay, etc. And then knowing your anatomy and certain stations. It's all about stations, and we all start off at the OG junction. There are certain things to look out for in the duodenal bulb and in the D2, what we look for. We will go through that in the next few slides. So indications for EUS, it's for evaluation of luminal GI malignancies, to look at submucosal lesions, evaluation of pancreatic biliary disease, mediastinal disease, perianal disease, extraluminal abnormalities, and of course, therapeutic applications. Today, we will concentrate mainly on luminal GI malignancies and the evaluation of submucosal lesions. So apart from that, with HPV disease, EUS has been is often used to look at gallbladder stones, CBD stones, evaluate pancreatitis, cysts, and HPV cancer. It is complementary to cross-sectional imaging, that is like CT and MRI, and it's used to guide treatment. So you saw this image earlier. When we use EUS to image the GI wall, you can see that they are very close correlates with histology. So there are basically 5 layers, but there are 4 interfaces. The first is actually the interface between the gastric lumen and the epithelium. And then the first dark layer that you see is actually the muscularis mucosa. Then the white layer is the submucosa. The second dark layer is the muscularis propria, and outside that is the serosa. Okay, so if we understand that, you can do a lot of staging of luminal cancer. EUS images correlate very well with histology, but because we only have a 4 to 5 centimeter radius, it's a local regional staging that we can do. So when you stage cancer, this has to be used with CT, MRI, or a PET CT because distant metastases cannot be ruled out. So it's excellent for staging of esophageal and rectal cancer. And we know the AJCC and the TNM classification of cancers, tumor, node, and metastases. So EUS is most accurate for T and N staging. For M staging, it is limited, but you can still see ascites, which you can sample, pleural effusions, you can look at liver metastases, lesions in the left adrenal gland, all these can be sampled. Staging by EUS can determine whether the treatment can be endoscopic or whether the patient needs surgical resection or there is a need for neoadjuvant therapy. So EUS has been shown to alter management and is cost effective. So we start off with esophageal cancer. I think many of us would be having patients like this. And you can see that EUS has excellent local regional staging. It has an overall accuracy of 90% for T and N staging of esophageal cancer. And you can see, like in this situation, the tumor is T1 because it's invading submucosa. If it touches the muscularis propria, it is T2. If it has gone past the adventitia, that's T3. And if it touches the aorta or any external adjacent organs, that's already T4. So EUS can be used to guide treatment based on the tumor stage. It can tell us whether the patient requires neoadjuvant therapy. If there are lymph nodes, if you're using a radial scope, then you will have to switch to a linear scope to try and sample the celiac node, which is very important in esophageal cancer staging. One of the limitations of EUS in esophageal cancer is if there is a stricture. So as Dr. Sandy mentioned earlier, in some cases, we would dilate the stricture and then pass the scope down. You need to be very, very careful when you do this because there is a risk of perforation. Often you can even just scan just slightly above the stricture, but of course that's not ideal. Again, operator variability and the learning curve is important. So this is a case I'd like to just share with you, something quite commonly encountered. 56-year-old man who presents with dysphagia and weight loss and has a mass in the lower third of the esophagus. On the CT scan, they're not sure the mass is close to the aorta, not sure if there are lymph nodes. So there are various options for this patient. Does he go straight to surgery? Can he receive neoadjuvant therapy? Is it palliative? So in EUS, the TNM staging directs therapy. So if the lesion is within T1 or T2, there are no nodes, the patient can go straight for surgery. If it is T3 or N1, you can have neoadjuvant therapy. And if it's T4, that's palliation. Yeah, and M stage, as I said just now, you need to do a CT or an MRI to exclude distant metastases. So in this image, you can see this is the radial scope, and this is actually an esophageal mass. And this is the aorta, which is adjacent to this mass. And you can see that it is actually stuck to the aorta. There is no clear plane between the mass and the aorta, and this makes the stage T4. Now, while we're in the esophagus is also a window into the mediastinum. And we use EUS a lot to stage lung cancer as well, because mediastinal nodes, especially the subcarina and aortopulmonary nodes, are very easily accessible through EUS. And we know that 50% of lung cancer patients have mediastinal lymphadenopathy at the time of diagnosis. So EUS is not just for the GI tract, it's also for lung cancer. In the stomach, apart from evaluating gastric lesions, which we will go through, we can look at the body and the tail of the pancreas very clearly, and we can evaluate cancer and cysts in that manner. In the stomach, gastric cancer, EUS has limited accuracy. It's very good for looking for infiltrated paragastric lymph nodes, but the T staging and N staging is not as great as it is for esophageal cancer staging. So it's between 60 to 90%. EUS is extremely useful for early gastric cancer, where we can use it to differentiate the need for ESD, endoscopic submucosal dissection. So you want to see if the lesion is, just concentrated to the mucosa or it has gone into the submucosa, and guide therapy that way. Now, this is images of thickened gastric folds. They all kind of look similar. I think many of us would have seen this when you do endoscopy. But what are they really? When you look at it on endoscopy, it could be linitis, it could be varices. You might be afraid to biopsy. I would be afraid to biopsy if there were juicy varices. But with EUS, you can see you have very nice images. This is actually a maltoma, thickened mucosa here. This is menetrier disease, circumferential thickening, a benign disease. These are actually varices. If you apply Doppler, they will light up very well. And this is linitis plastica, and this is a little bit of ascites that is present on EUS. Okay. And then when we move down the GI tract, in rectal cancer, EUS is used to evaluate rectal tumor depth and involvement and whether the anal sphincter is involved. Again, accuracy is pretty T3 and T4, but 73% for T2 staging. For rectal cancer, the advances in MRI is so fantastic that MRI, unfortunately, is the preferred initial local staging choice in many centers, and EUS is reserved for certain cases where, they're not sure whether it's T1, T2, whether EUS FNA is needed for nodes that are present. And in many places, if EUS is present, it is done together. You have an MRI and an EUS together. The next big area where radial EUS plays a big role is evaluation of submucosal or subepithelial lesions. These are usually incidental lesions picked up on endoscopy, and EUS is the most accurate method for evaluating these tumors. We can determine the size, the margins, the origin of the layer, as I mentioned earlier, whether they are adjacent lymph nodes, whether EUS is required, is endoscopic resection possible, and basically EUS can help us to decide whether this patient needs further treatment, or is it safe to just observe the patient, or to tell the patient, listen, there's absolutely nothing to worry about, and move on. So when we look at this lesion, it could be a lipoma, it could be a leiomyoma, it could be a GIST, and very often it looks this size on endoscopy, but on EUS you can see that it actually extends even deeper extramurally, and it's actually much bigger than what it looks like endoscopically. And these are characteristics that Sandy has already explained earlier. These are some basic terminology that you need to be familiar with. So anechoic, it's all dark and it means that it's fluid. Hypoechoic, it's darker than the surrounding structures. Isoechoic, where it's kind of similar. And then hyperechoic, where it's whitish in color. And based on all these, and based on which layers it's originating from, there is a differential of what these lesions could be. So for example, hyperechoic, we think of fat, and it's usually a lipoma. And if it's hypoechoic or anechoic, very clear structure, is usually fluid and it's usually a cystic structure. In between, it could be any of these. Again, when you look at these lesions, gastric submucosal lesion could be anything. This is a lipoma, this is the gallbladder with some sludge, and this is actually a GIST. You can see the lesion arising from the muscularis propria. Duplication cysts, these are rare congenital lesions seen in adults. Some patients are asymptomatic, while others can present with symptoms. Very often it's an incidental finding. Again, EUS can make that diagnosis. Pancreatic rest is aberrant pancreatic tissue, occasionally found in the stomach as well. So again, this is something that we can see that there's a characteristic appearance with an anechoic tubular structure, which is actually a duct, which you can see on the EUS image. When we look at the layers, whether it's the second layer, the third layer, the fourth layer, we can have some idea of the lesions that it could be. Yeah. So usually in the submucosa, there's mainly this lot. Of this whole lot, I would like to concentrate on two lesions which I think are quite important. Carcinoid tumors, we don't call them carcinoid anymore. They're all called neuroendocrine tumors, and GIST tumors, because these are the two lesions with the highest malignant potential. So this is what a neuroendocrine tumor looks like. And you can see that most commonly it arises from the submucosa, the white layer. You can see a nice expansion of the submucosa and the lesion over there. And you know that gastric neuroendocrine tumors, there are three types: type 1, type 2, type 3. Type 1 and type 2 are the more benign ones. Type 3 is the more worrying one. So if you see a solitary large lesion that is suggestive of a neuroendocrine tumor, you'd be quite worried about it. Yeah. Similarly, in the duodenum and the ampulla, you can have nodules that are actually neuroendocrine tumors. Any lesions more than 2 centimeters are aggressive and are associated with lymph node and liver metastases. Again, EUS is very important in determining which lesions can be removed endoscopically. In ampullas, where the endoscopic ampulectomy is possible, so EUS can evaluate all these. Rectal nets, this is the commonest neuroendocrine tumor picked up on endoscopy. And, this is just a benign looking, smooth, small nodule, which we see. And I think we've probably missed loads of these, 20 years ago. With the technology being fantastic, we're seeing all these lesions now. And if you see this, think of a rectal net. Again, incidence has increased in the last few years because of the better technology. Anything more than 1 cm is a bit worrying because they have a high tendency to metastasize to the liver. So patient selection for endoscopic removal is important. If it is small, less than 1 centimeter within the mucosa or submucosa, you can try endoscopic resection. Anything between 1 to 2 cm is a bit uncertain, and definitely more than 2 centimeters, I would not try to remove it endoscopically. I would refer this patient for transanal wedge resection. So endoscopic mucosal resection, I think a lot of us are familiar with this. The simple way of injecting some saline and lifting, that lift sign. If you're happy with that, you can carry out your snare polypectomy or with cap or without or duets. And, EUS is important in these luminal lesions because they basically help us to select the patients for curative resection through EMR or ESD. ESD is the deeper layer. Again, you've got to be pretty sure that there is no involvement of the muscularis propria and adjacent lymph node metastases before you subject these patients to ESD. So minimally invasive endoscopy, where the lesions are located within the mucosa or submucosa, muscularis propria not involved, they are small, no metastases present, you can carry out these procedures. With gastrointestinal stromal tumors, they are quite characteristic on EUS. They're well circumscribed, hypoechoic. The only confusion is it's very similar to a leiomyoma. So if you see this dark hypoechoic mass arising in the OG junction or the esophagus, they're more likely to be leiomyomas. If they're more in the fundus or the body of the stomach, they tend to be more GISTs. But you can't tell sometimes, and the accuracy is improved with EUS FNA. There are some features of malignancy that you can see on EUS. So a heterogeneous, not a pure hypoechoic area. You can see it's a mixed echo texture, irregular borders, they are large. All these are worrying signs, for a potential high Ki-67 with those. So, EUS gives you a lot of information. You can look at the layers based on the layers and their appearance. You can sort of come to a differential diagnosis of what lesions you're looking at. And based on all those informations, you can decide whether no further investigation or follow-up is required, or whether these patients need close monitoring or they need FNA. This is wonderful information you can get with endoscopic ultrasound. And finally, just to finish off, EUS of the pancreas. So while you're in the stomach, the first station that I always concentrate on is the gastroesophageal junction. From there, you can look at the neck, body, and tail of the pancreas. You look at the splenic vein or the pancreatic duct to guide you. And in its journey throughout the pancreas, you can look at the left adrenal gland, the kidney, the spleen, bits of the left lobe of the liver. In the duodenal bulb, you see the head of pancreas very well. You have the stack sign, which is your bile duct, PD, and your portal vein. And you can evaluate the ampulla well as well. And applications of EUS for pancreas is for many things. That's another day's lecture altogether. So this is some terminology you will hear. A seagull. This looks like a seagull. This is the left adrenal gland. So occasionally you have lung metastases, you have tuberculosis, you have incidentalomas. So you'll see a big mass there. This is the aorta with the celiac trunk bifurcating into the hepatic artery and the splenic artery. This is a very important landmark because this is where you would find celiac lymph nodes. This is the portosplenic confluence, the portal vein going to the splenic vein. So this guides you to the neck, body, and tail of pancreas. Yeah, some common terminology that you will be hearing when you go for training. In the duodenal bulb, this is the stack sign. So this is the head of the pancreas. You have the bile duct, pancreatic duct, portal vein, and sometimes you see the gastroduodenal artery running through. This is the stack sign. This is the gallbladder, nice clean gallbladder, and this is the bile duct with a lovely stone, and you can't really see the shadow, but that's a CBD stone. And apart from all that, this is the left lobe of the liver. This is what a liver metastasis looks like, very easily accessible for FNA. This is ascites. This is a slightly irregular bordered liver. You can see liver cirrhosis, ascites. And sometimes you can see peritoneal involvement, peritoneal seedlings, which can be biopsied as well. And once in a while in Asia, this is something that you can encounter. A guess, with no time to get the feedback from the audience, but this is a worm that has found its way into the bile duct, a criggly worm. So final slide, endoscopic ultrasound is a wonderful tool. It is, I think a lot of people who go into EUS get very passionate about it, end up loving it. There is a steep learning curve. I would say go through the trouble and the pain because it's really worth it at the end of the day. And it is a multidisciplinary approach. You are not working just with yourself. You end up working with your surgeon, with your radiologist, with your oncologist, your pulmonologist, your respiratory physician. It's really very rewarding. So in conclusion, EUS is firmly established in the local regional staging of cancers of the esophagus, stomach, pancreas, extrahepatic, bile duct, anal canal, and rectum. It is complementary to cross-sectional imaging, CT, MRI, PET, in the evaluation of all these diseases. It has a major role in the diagnosis and management of submucosal lesions, as we've gone through in stone disease, whether it's bile duct or gallbladder or pancreas, in pancreatic cystic lesions, and a thorough understanding of the anatomy and experience are key to the success of EUS. And it has been proven to be a cost-effective guide to treatment and should be part of the armamentarium in endoscopy centers. Thank you very much.
Dr. Sandy, unmute.
Mute. Okay, I think right. Am I on? Can you hear me?
Yeah.
Yes.
Okay, so thank you for that very thorough lecture, Sharmila. Sharmila, I think we have, caught the attention of the audience very well, because I'm getting a lot of questions now about EUS. It looks like some people are definitely showing some interest, and we're happy about that. But we shall move on now to our next speaker. Oh, before that, let me tell you, for anyone who came in late, if you were not able to join us from the very beginning of the webinar, Pentax will be sending you a link shortly so that you may be able to watch the video when it's a good time for you. And also, please don't forget to put in your questions at the query box that you have on your monitor, and then we will be answering all the questions after all 3 lectures are done. All right, so our next speaker is an equally prominent lady endoscopist from Thailand. She is current program director of the prestigious World Gastroenterological Organization, or WGO, WGO Endoscopy Training Program at Siriraj Endoscopy Center in Thailand. She is also Associate Professor of Internal Medicine at the Siriraj Hospital of the Mahidol University in Bangkok, Thailand. She completed her fellowship in gastroenterology at the University of Michigan Health System in Ann Arbor, Michigan, where she later also completed her fellowship in advanced gastrointestinal endoscopy. Without further ado, please let's all welcome Dr. Nonthalee Pausawasdi. Please, Nonthalee.
Thank you very much, Sandy, for the kind introduction. I'm going to share my talk with you guys. Can you see my slides? Okay. Is it showing?
Yes, it's good.
Okay, all right. And you hear me okay, right? So first of all, I'd like to thank the organizing committee for giving me the opportunity to participate. And my talk today is going to be focusing on basic EUS of pancreatical biliary system. I will cover 3 aspects, including indications, basic technique, and EUS guided tissue acquisition, and usefulness of the linear EUS in practice. So I'll give you some examples of cases that we do on a daily basis. The linear EUS can be performed for diagnosis, tissue acquisition, and therapy. It allows the assessment of biliary system, including stone assessment, stricture, and the anatomy of bile duct and pancreatic duct. It also allows us to evaluate for any lesions in the pancreas, including cystic and solid cancer, or even chronic pancreatitis and pancreas divisum. Gallbladder is one of the things that a lot of people like to use EUS for thorough examination. Because of the linear EUS has a working channel that allows the needle to go through, and I will show you some pictures of that. And with that option, it gives us a means to obtain tissue acquisition using either fine needle aspiration or biopsy needle. Furthermore, over the past 2 decades, the indication of EUS has been expanding to therapy. For example, drainage. It allows us to drain pancreatic fluid collection, necrosectomy, and drainage of pretty much any intra-abdominal collection if we can reach with the EUS. Also, this past recent years, EUS allows us to create anastomosis, including biliary enteric anastomosis, like hepaticogastrostomy, choledochoduodenostomy, and also gastroenteric anastomosis, like EUS-guided gastrojejunostomy. Injection therapy has been around for many years, including celiac plexus neurolysis or celiac plexus block, vascular therapy like glue or coil embolization of gastric varices, or even oncology therapy like chemo injection through EUS or alcohol ablation, or even fiducial implantation for the radiation therapy. So the main difference between radial and linear, I think, is that with the linear scope, it allows you to visualize the needle path, and therefore you have an option of performing tissue acquisition and therapy. And I think this is probably one of the reasons why Sharmila had mentioned earlier that if you can choose one scope, she would just go ahead and choose the linear and learn the linear, because I think it can, provide diagnosis as well as a therapeutic option. One thing, though, that I'd like to point out is that when you start doing EUS, especially when you pass the linear scope, the tip of the linear scope is long and stiff, so therefore you got to be very careful during the intubation. There are three main maneuvers to negotiate the scope. Up-down control, when you have to go through angulation. Torque, including counterclockwise and clockwise to scan through the whole lesion. And advancing and withdrawing the scope when you have to examine distal and proximal end of the lesion. It is a good practice to do EUS using station-based or a systematic approach. And there are different ways of doing station-based, but what I have found to be quite useful is that you can go through mediastinum, gastric, and duodenal station. Because my talk is going to focus on the pancreaticobiliary examination, so I'm going to go through with you the HPB examination using a linear scope based on station. We're going to start with the gastric station. In the gastric station, what you're going to see here is that the scope is going to be in here in the stomach. And with the span of the linear scope, it's going to allow you to see segmental images of the pancreas and bile duct. Okay. From the stomach, you can see pancreatic neck, which is right about here, body and tail. You can see left lobe of the liver, which is going to be right around here. Celiac axis, you can see lymph node around here as well. You can see a lot of vascular structure like portal vein, splenic vein, and part of the SMV. Definitely you can see portal vein, SMV, and splenic vein confluence. You can also see SMA from there. How do one find pancreas? There are probably different ways of finding pancreas, but my ways of finding it is that I have two methods to find the pancreas. Number one is I can just follow the portal vein, which is right about here from the hilum, go to the portal vein, and then from portal vein, you go and you identify the confluence of the portal vein, SV and SMV. And then right about here, you're going to see the neck of the pancreas. And once you clockwise rotation a little bit, you're going to see more of the body. The other more classic way of finding the pancreas is that you identify the celiac and you follow the celiac and go to splenic artery. And the pancreas is going to be right above the splenic artery. Here is a picture, a linear EUS picture of celiac axis. This is aorta, this is the celiac. Here are some more pictures of the neck. Here, as you can see here, this is the a splenic vein, SMV, and portal vein confluence. Right here, you can see the neck of the pancreas. Around here is going to be body. If you keep clockwise, you're going to see more of body and tail. Below the SMV, you're going to see pancreatic head. This is another image of pancreatic neck, and you see a small tubular structure right here, which is pancreatic duct. This is more images that you can see the pancreas from the gastric station. This is body and this is tail. Right next to the tail, you're going to see the spleen. To the left of the spleen is going to be left kidney. I'm going to show you a quick video on how we do the gastric station using the linear. Now, as you go in, I'm gonna fast forward the video to the point that you can just see the anatomy better. Okay, right here, you can see celiac coming off of the aorta. Once you follow the celiac, it's gonna split into splenic artery. Once you follow the splenic artery, splenic vein is coming below. See, you can see the pancreatic body right away. What just flashed by was pancreatic duct, a small tubular structure right there. If you're not sure, you can put the flow on. Here you just saw the splenoportal confluence went by. Right here, this is the SMV dividing head from the neck. If you follow the SMV, here's portal vein, that's a splenic vein. That's a splenic artery. If you follow the portal vein, below portal vein was the CBD. Okay, so here's an example. The CBD right there, pancreatic body is right here. Okay. So here, as you do more of this, you will understand more of the fine movements and the maneuver to get the image that you would want. Moving on from the gastric station, we're entering the duodenal station. From the duodenal bulb, you're going to see pancreatic head, which is right there. The scope is right here. You will also see distal CBD as depicted right here. CHD you can also see as well. And you can also see portal vein confluence with the splenic vein and SMV. You see a part of the right lobe of the liver and gallbladder right here. What else can you see? If you go deeper into the second portion of the duodenum, you're going to see uncinate process, ampulla, pancreatic head, and the great vessels, as well as SMV and SMA. Here is the bulb station. You can see portal vein right here, SMV right there, splenic vein is right here. This is head of the pancreas. This is distal CBD, which is an anechoic tubular structure with a negative Doppler running into the head of the pancreas. So in the bulb, what you would want to see is as you enter the bulb, you're going to see CBD right there, pancreatic duct right here, and portal vein below. If you torque a little bit, you might see splenic vein coming this way and SMV running along pancreatic head. And if you turn clockwise rotation and push down a little bit, you're going to see more of the distal CBD with the PD underneath and ampulla. In this area, you'll see most of the time right kidney. Sometimes you can see the right adrenal gland as well. Let's just show you some videos of the bulb station. Here, this is CBD running through the head of the pancreas. The head is very beautiful here. Right below that is the pancreatic duct that just went by. And you see vascular structure. This is pancreatic duct right there, and this is the CBD. If you follow CBD, push in a little bit, you're going to see the CBD is going to ampulla, which is right about here. Here, you can see more of the vascular structure. Right here is the portal vein, there is SMV running below the pancreatic head, and you can see a knob of splenic vein coming down here. Okay, so this is the bulb station. So what you want to see, remember, you want to see common bile duct, you want to see pancreatic duct, you want to see portal vein over here, SMV running along this way. Okay, all right. So from the bulb, if you push the scope further, you're going to get into D2. In D2, you're going to see ampulla better, you're going to see CBD, and you're going to see PD. And the most important thing that you'll see in the D2 is that when you have an uncinate lesion, uncinate can be seen from the gastric station as well, but I think it's more difficult to get that image. So you can achieve the uncinate image at the D2 very nicely. So here's the uncinate process right there, and you can see the vascular structure below it, or here's more image of the uncinate. I have a short video to show you. So you want to push your scope down into second part duodenum, as you see the great vessels, and then you keep pulling back the scope. As you pull back the scope slowly, and you torque clockwise and counterclockwise, you're gonna start seeing the uncinate coming into view just below the probe. You see that uncinate right there, and within the uncinate, you're gonna start seeing a tubular structure, which is pancreatic duct. Which should be coming in very soon. You'll see pancreatic duct right here, right there. You will see two duct. One is CBD, the other one is pancreatic duct. CBD is usually above, pancreatic duct is a little bit below. So as you scan through the uncinate, you're not gonna miss any lesions that may be located in the uncinate process. Okay. Now, what else can linear EUS offer besides from a thorough diagnostic procedure? It offers tissue sampling and therapy. Here is where the needle comes out, and you can see the needle path using a linear scope. How do we do FNA? I'm not going to go into detail about this, but I'm going to show you here is where the needle is going to the target lesion. And you can, with the linear scope, you see the needle path, and then you can use different techniques for FNA. But this is what you're going to get. Once you complete, this is how the setup is going to be. A needle goes through working channel, you attach it there, and then you're going to push the needle out towards the target tissue. Once you get the sample, this is an FNA needle, so you get cytology, and you can also put the sample in formalin or cytolite to perform histology as well. We call this a cell block. Okay, this is the beauty of doing EUS FNA. Now, I'm going to go to the last part of my talk, which is how useful it is of EUS in daily practice. Here's a case of a patient who had undergone rectal surgery for rectal cancer. On follow-up endoscopy, a subepithelial lesion was documented, and initially there was some concern of recurrent rectal cancer. Then after performing the EUS, you can see this is anechoic, and you listened to Sandy's talk earlier. When you see anechoic, that represents cystic lesion. And after FNA, you see a lot of proteinaceous material. Therefore, this is more like a cystic lesion with protein inside, not a recurrent cancer. Here's another interesting case. This patient is a nurse who presented with a pancreatic mass on a checkup ultrasound. Then she went ahead to get a CT scan and MRI. And as you can see that on the CT scan and MRI, you can see a fat-containing lesion right here. EUS was performed, and you can see a hyperechoic lesion within the pancreas. And if you remember Sandy's talk, hyperechoic is usually fat or calcification. This patient, after EUS, we were thinking of lipoma, and after FNA, we see a lot of fat tissue consistent with lipoma. So we saved her surgery as well for this patient. Another interesting one, this is a patient who has CT for a non-specific abdominal pain. CT demonstrates an arterial-enhancing lesion at the tail of the pancreas. The initial impression was pancreatic net, with the differential diagnosis being accessory spleen. An EUS was requested along with an FNA. This is a lesion. The echogenicity of this lesion is very similar to the spleen. After the FNA, you see pretty much a splenic tissue, and the diagnosis of accessory spleen was made. The patient didn't have to undergo surgery. Another pancreatic incidentoloma on a CT scan is symptomatic cystic lesion with a questionable solid content inside. EUS shows you a honeycomb appearance, cystic lesion consistent with serous-cystadenoma. So the diagnosis can be made, and the patient can be followed without having to undergo surgery. This one I found very interesting from the literature. This patient presented with systemic symptoms, including weight loss, fever, and prolonged fever, and a CT scan showed pancreatic lesion, which is a mixed cystic and solid lesion. An EUS FNA was performed, and it was positive for AFB stain consistent with tuberculosis. So this patient was treated with anti-tuberculosis agent with complete resolution of his symptoms, and surgery didn't need to be performed. Had it not been diagnosed by EUS, this patient might be subjected to surgery, although he presented with prolonged fever that should raise concern of systemic infection. This is another interesting one. This patient presented with obstructive jaundice, underwent a CT scan from an outside hospital, which showed a diffuse dilatation of intra and extrahepatic bile duct, including distended gallbladder. This patient was sent to surgery for a Whipple due to an initial diagnosis of possible small ampullary cancer. Luckily, the surgeon who got a consult didn't see any obvious cause of obstruction. Therefore, he sent the patient to us for an EUS. As you can see here, you see this a very long and diffuse hyperechoic material with posterior acoustic shadow. And we saw a stone right here. This is a hyperechoic lesion with posterior acoustic shadow. So we thought that the whole CBD was just packed with stone. Therefore, ERCP was undertaken. And this is what we saw. We saw a bunch of stones throughout the bile duct. And after the patient had a complete stone removal, he his symptoms are completely gone. He's back to his normal without having to undergo Whipple's operation. So here are some examples of how useful it is for EUS in a daily practice. The last thing, which I will not go into detail, is the intervention or therapeutic EUS. Over the past 2 decades, EUS has been used for therapy like drainage, as I mentioned, anastomosis, and injection therapy. I like to point out, though, that all of these areas of therapeutic options are very important and emerging, especially the creation of biliary enteric and gastroenteric anastomosis. A lot of research is being done. So I think for those of you who have completed your training in basic EUS and you feel comfortable enough and you have enough experience for basic EUS, then in the future, interventional EUS is the way to go. So in summary, linear EUS, it allows you to get a definite diagnosis using FNA or FNB. When intervention is needed, linear EUS can also provide you the therapeutic option. For diagnosis, you might find multiple non-surgical conditions like infection or inflammation or even Stone's disease, and this will help you avoid unnecessary surgery. For intervention, therapeutic EUS is definitely an alternative, and for some of the indications, it is the mainstay treatment. For the advances in therapeutic EUS, if you can do it, it will also help avoiding surgery in an unfit patient as well. So with that, I'd like to thank you for your attention.
Thank you very much, Nonthalee. That was an excellent lecture on linear EUS. Okay, so we are about to start on our 3rd hour. So we only have maybe... am I on? Can you hear me?
Yes.
We are about to start on our 3rd hour. So we have maybe a few minutes to answer a few questions. But so I have been getting personal text messages from some people and some fellows. They're asking. Okay. Well, that's not me. That's okay.
Yeah, it's done. It's done.
Is it good? Okay.
Yeah, you're good.
Some people are asking about training. Looks like we have some interested people. I know I have my fellows in one institution that I go to when they're saying that they're enjoying the lectures and they hope that they're able to get to train on EUS. Well, maybe I can start by asking you your experience about how you were trained or where you went and how long it took you to get your training on EUS. Maybe Sharmila, you want to be first? Can you tell us how you learned to do endoscopic ultrasound?
Sure. I was first exposed to EUS 20 years ago when I was still in Dublin. There was a lady called Dr. Eileen Clark. She was doing EUS and they had just got the machine. And I was just watching. I didn't even touch the scope. It came probably the last 6 months before I came back to Malaysia. And I came back to Malaysia and lo and behold, we actually had the EUS machine, but we didn't have anyone trained to do it. And at that time, there were no videos, there were no YouTubes, there were no CDs, there were no books on EUS. EUS was just starting. And we had Kenjiro Yasuda from Japan who would come to Malaysia for 1 or 2 days a year. So those 2 days, everything made sense. You'd stand next to him and you'd watch and you'd be like, yes, okay, this is it, this is it. When he leaves, nothing made sense. So in 2 days, things made sense. And then when he went back, you're waiting for a whole year before he'd come again. And then my mentor is Dr. Ryan Ponudure, who trained in America. And when he came back to Malaysia and worked in Selayang Hospital, where we worked together for about 10 years, he was trained in EUS. And he's really responsible for bringing EUS into our country and to the Asia Pacific as well. And so I was very fortunate to be with him, and I learned all my EUS watching. At that time, I was more excited about learning ERCPs. I wasn't really bothered about EUS, and then I got pregnant and I couldn't do ERCP. And then Ryan was like, look, just learn EUS. I said, no, I can't look at anything. It's all black and white. I don't know what I'm looking at. And it was his encouragement, and I just persisted, and then one fine day I thought, oh my God, I love this. Today, 20 years later, I've had quite a lot of trainees in EUS, and what I would say to someone is, if you're really serious about learning EUS, I think it's very hard to learn EUS and ERCP at the same time. They're both interventional, they're both difficult and different skill sets. You need to choose and concentrate on one first. When you've mastered that, you can move on to the other. You need to probably be in a high volume center for at least 6 months to a year. You got to dedicate that time. You have to take that time out and make yourself get to that place. And it has to be a high volume place. And as I said earlier, you need to know what is normal. You need to know what's normal before putting the scope down and biopsying and being excited about puncturing this and that. The learning curve is steep, but it's rewarding. So I would say high volume, pick your centers, pick your mentors, and focus, be dedicated to it. And yeah, that's what I would say.
Thank you. What do you think, Nonthalee? I mean, would you have any particular advice for those who are interested in pursuing, learning endoscopic ultrasound or pursuing expertise in fields such as EUS? Can you tell us about your experience, about how you got to train with EUS?
Sure, yeah. My way of training was quite different from Sharmila. I think I was a few years behind Sharmila. So she was in the era of learning by doing and trying to attach to a professor who has experience. But I have gone through a formal training of the advanced endoscopy, and I was trained in EUS and ERCP at the same time within a 1 year span. And I found that to be very, very helpful. I think I'm leaning towards structured training as opposed to attending courses. Some people don't have the time to go to attend a structured training like 6 months or a year. So then they would have to go to different workshops. I think that's good when you have some basic knowledge or some basic skills and you want to learn from the experts, tips and tricks of how they do things. I think those hands-on workshops are very helpful for that purpose. But to get the understanding of EUS images and how to maneuver your scope and how to get the images that you would want, I think a structured training for at least you're going to need at least of 6 months of training, assuming that you're at a high volume center, to be able to get something out of it. And remember, even if you've gone through a structure or dedicated advanced endoscopy training program, the very first day that you finish your training and you start doing the procedure by yourself, you're going to be able to see things for about 60 to 70%. The other 30% you might not see and you might not know where you are. So I think it's going to come with time, but with some good fundamentals, I think you know you're gonna get it, because most of us actually do it that way, right? Yeah.
Okay, well, thanks for that. I also had the same kind of formal training where I did learn endoscopic ultrasound and ERCP at the same time. So we had pretty much a similar training program, I suppose. But what I just want to tell the people now, these fellows who are interested in learning endoscopic ultrasound, they actually are very fortunate that within their centers, they already have people performing the procedure, so that even before they are able to find their training programs, they already have the opportunity to learn. So they should take the time to watch their mentors, see how they're doing their procedures. Maybe if they're not made to hold the scope to do EUS, they already have the chance to learn about the images that are showing up on screen, and which structure is supposed to be where, and when do you see them, and what part of the stomach or what part of the intestine. So that would be my advice for those fellows or GIs who are interested in learning endoscopic ultrasound. You just need to just take all the opportunities that are available. So watch as much as you can, and then you find a place where you can go, where you can train. Okay, we have a few questions not related to training, but maybe related to, let me just see, to somebody is asking about, and I hope you don't mind this question, maybe you can answer, Nonthalee, what is your favorite EUS brand? They're trying to see if they can start doing EUS in their units, or maybe they can purchase some equipment. I hope this is a fair question for you to answer.
Yeah, sure. I'm gonna give you the pros and cons of each brand, I think, because I've had experience in all the 3 brands. For Pentax, I think the most special about Pentax is that the image resolution is pretty much, I think, unbeatable. Very good. When I started my EUS training, actually, I started off with Pentax. And I found that the old Pentax was very stiff and very difficult to maneuver. But that issue has been taken care of by the new version of Pentax. I think with the newer version, the most recent one, actually, the flexibility is there, and I think that the maneuverability is much better now. The only thing is that if you use Pentax scope, the angle of Pentax scope is each brand has different angle. So you got to be familiar with the angle of the needle of the Pentax scope that's going to come out, which I think with time you're gonna get used to it, and you're gonna know how you can position your scope during the FNA. Olympus, I think the good thing about Olympus is the scope maneuverability. I think the scope is very flexible. It's easy to go to D2. The image quality, though, however, the Olympus machine itself, it doesn't give you as nice of an image quality. Although with the newer version, they might take care of that. For Olympus, if you want a really good image quality, then you would have to use it with the Aloka 10 or F75, or even now they have the even newer version of that. I think that's going to be a good combination. Fuji has the least experience with, but I used to use the older version of Fuji scopes. I think that with the radio scope, I found that to be somewhat challenging. Linear scope, however, is quite good, and the image quality is good. So I think that each brand has the unique feature of their own. So I think that when you want to buy a new machine, then it would be nice for you to try it first and see which one you feel the most comfortable with, along with the price, how much you can afford, because obviously the price is different, and that may be an issue as well. Yeah. And the more features you want in your machine, the expensive the machine is going to get. Like if you want contrast, elastography, and a bunch of other things, it's going to add more values to that.
Okay, that's great.
Yeah.
Thank you. So it's, I think we have time for maybe one more question. Someone is asking, do you think that it would be worth investing in a mini probe? How often do you end up using mini probes, and how are they compared to using maybe a radial echoendoscope? Maybe Sharmila can answer the question.
I have never really needed to use a mini probe. So I used it maybe 20 years ago, but not recently. So I think you can get whatever information you need with a radial and the linear. Yeah. Nonthalee? Yeah.
Yeah, the only occasion that I would use mini probe, I'm still using it, is when I do the T staging of early esophageal cancer. At our center, we have a program for early esophageal cancer screening, as well as ESD for esophageal cancer. So the endoscopist who performs the procedure would ask me to do EUS examination of the lesion before he decides to perform ESD. And in this situation, I find that mini probe allows you to see 9 layers, which is what they really like, the 9-layer thing. But the radio doesn't give you that great of a details in terms of the layers of involvement. I used to use mini probe for the bile duct as well, but there's some data showing that IDUS is helpful in evaluation of bile duct stricture. I think that might be the other condition that you can use, but I'm not a big fan of that. Yeah, I found it to be challenging, and the cholangioscopy might be more user friendly.
Okay.
Yeah.
Okay. So maybe do we have some more time? Maybe just one last question. I know I said that was the last question. Maybe just one last question. We have Dr. Aguila, Enric Aguila. He's asking about whether or not you recommend a CT or an MRI first before subjecting a patient to endoscopic ultrasound, or do you maybe straight from a regular transabdominal ultrasound go ahead and perform endoscopic ultrasound right away? What do you think, Sharmila?
Again, it all depends on the situation. And as I said, it's like a jigsaw. You got to know the case. You got to know the patient. You have to speak to them, examine them. So if it's a situation where you think it could be a possible stone, you don't need to get a CT or MRI. if it's patient with abdominal pain, jaundice, fever, you can go straight to an EUS to see whether it's a stone. If it's someone with painless obstructive jaundice, weight loss, you suspect a tumor of some sort, you can get a CT and then you can do your EUS, or vice versa. Sometimes it's useful to have a CT or MRI if you think it's a tumor, because it sort of guides you to focus on certain things. But it all depends on the situation, really. Yeah. And of course, not everyone has EUS. So in your center, if EUS is not readily available, then, a CT or MRI or MRCP if you think it's a stone or a cholangio, or, yeah.
Right. Okay. Thank you. Well understood, Sharmila. So we have come to the end of our webinar. We hope that you all were able to gather some interesting things you want to maybe pursue, and hopefully consider doing endoscopic ultrasound. I hope we were able to impart to you a little bit or some knowledge about endoscopic ultrasound, and I hope that when you go home, or you are home, so with the webinar, okay, I hope that you are able to maybe decide or think about how useful endoscopic ultrasound is, and I encourage everyone to consider getting endoscopic ultrasound in their own units, because really, now maybe these are what you might call advanced procedures, but later on, there will be more and more indications for endoscopic ultrasound, and it will just be a necessary procedure to be able, necessary procedure for you to have in your endoscopy unit, and everybody just needs to have endoscopic ultrasound available. Okay, so before we close, I would like to thank our speakers, Dr. Sharmila and Dr. Nonthalee. Also, thank you to the Philippine Society of Digestive Endoscopy and WIGNAP for this awesome collaboration. We hope that we have another one pretty soon. We would like to thank our sponsor, that's Pentax Medical, as well as NPK, which is the distributor of Pentax in the Philippines. And I guess that's it. Good evening, everyone. I hope that you all stay safe and take care. Bye.
Thank
Bye.
you, everyone.
Thank you.
See you guys later. Bye.
See you. Bye.